for the reflection grid for the shoulder. Obviously made notes again. So Mark, a 17-year-old, obviously tells me he's an adolescent, um, which is just something to make note of based on how long has he been playing said sport that we're about to talk about, the different issues that come with being an adolescent and whatever the sport is, et cetera, et cetera. He's a right-handed volleyball player, so an overhead athlete presenting with right shoulder pain, so obviously chief complaint. Um, Feels whenever he spikes or serves the ball. So obviously this is a repetitive overhead motion that we're dealing with all the time. So in my brain right now, I'm thinking the whole, like kind of just anything and everything surrounding external rotation issues. Probably a little bit of abduction, but especially external rotation. So a lot of rotator cuff, labrum stuff, AC stuff, scapular stuff, postural issues, and things like that. Pain started last season. Mark said diminished during the months when he wasn't playing and then got progressively worse as his activity level increased. So here, as I noted, this just tells me that there's increased pain and activity, but when he rests, his pain decreases. And it's also a chronic issue, nothing acute. So nothing happened to him, no force had happened to him to cause his shoulder pain. He's just in pain with activity consistently. So the overhead motion is what's causing him issues. Pain was in the posterior aspect of the shoulder. So again, AC joint possibility, impingement, rotator cuff issue, like tendonitis, tendinopathy, scapular issues, again, imbalance issues, things of that nature. Keep looking at myself. The camera's right there, but whatever. Physical examination revealed a well-developed but thin young man who was not in distress. So although he's well-developed puberty-wise for his age, he's a little smaller. So immediately I'm thinking more so some sort of muscular issue, tendon issue, because we're just not strong enough to deal with the stresses that we're putting on our body at the moment. General examination was benign, and a joint-specific exam showed no asymmetry or atrophy. So bilateral evenness, basically. On inspection and no tenderness to palpation over the posterior and anterior soft tissues, which kind of goes against the whole rotator cuff impingement thing, but it is still possible to have these without tenderness to palpation, especially when you look at tendonitis, tendinopathies. It could just be part of the severity of the issue. However, expected, but not necessarily high in necessity for diagnosis in my book. Rotator cuff testing yielded intact strength for all four muscles, which is great. Again, sometimes can be expected to have lack of strength, but not required. Um, External rotation and supraspinatus testing elicited pain. So again, overhead motion and posterior pain. In my brain, rotator cuff really still strong. General joint laxity was observed with the ability to oppose the thumb to the volar forearm and hyperextension noted in both elbows and knees. So even though things like sulcosine and oh my gosh, I'm so blanking. The test where you like move when you're testing basically for instability in the shoulder in different directions, that is not like I expect those to be positive, which is fine. It's also normal in an overhead athlete for those to be positive. So again, fine, noted. And also the general laxity again is pushing me towards tendonitis tendinopathy because it's causing that extra stress of having those rotator cuff muscles have to work that much harder to hold that joint in space because it's already super lax and loose. And because the ligaments aren't as tight as they need to be, the muscles now have to overcompensate, which happens. There were no outward signs of connective tissue disease. X-ray film showed nearly skeletal maturity in a male with bony abnormalities, and the humeral head was located within the glenoid. So not really worried about any bony issues, not really worried about ligamentous issues, not too much. when it comes to like labral issues or anything, everything's where it's supposed to be. Um, so most important diagnosis, tendonitis, tendinopathy, that's kind of where my brain is. Again, elements against full strength and no tenderness. But again, it's possible. I would just like to see that, or that would just kind of make me a little bit more sure about it, but doesn't require that as part of the diagnosis. And then I'm still leaning towards I'm needing that tenderness to palpation over insertion of the humeral head. Wow, it got really dark when I turned the computer that direction. Um, Scroll down. These last two, I kind of keep going back and forth on, so I just kind of put them on there in whatever order, but kind of in my brain when I'm thinking of my differential diagnosis, these are on the same level in my brain. They're both kind of two, because to me, they both have the same, their elements against and their elements missing are both in the same category or same way the same in my brain. So 2 and 3 are kind of both twos for me rather than a 2 and a 3, but it's okay. So I just put them on here in kind of any order. So one would be the posterior impingement syndrome. So we're looking at all the normal pain, all the same stuff with the first one. But the biggest issue here is there's no tenderness, which technically is possible, but when you really get down to it, the lack of tenderness is kind of interesting because 9.9 times out of 10 with impingement, you're gonna have the tenderness whenever you push down the AC joint or push down just outside of the AC joint. Um, Also would expect some sort of range of motion deficit or extreme pain with said range of motion, which just wasn't mentioned. Um, Asymmetry typically, so I would see that like shoulder dip naturally, especially with an overhead athlete. And then it mentioned the x-rays. I would almost, I don't know if you would see this on an x-ray more so or an MRI, but I would expect almost to see that decrease because like sometimes you can see the minimal space, but I just can't remember which imaging that you would see that on. If you would see that, if the muscle is inflamed, if you would still see that in an x-ray, or if you'd have to go get an MRI to be able to see that the tendons are what it's inflamed. Don't remember, but I would expect that in some sort of imaging. And if you didn't see that in X-ray, then maybe we would go order an MRI to see that, um, or whatever the case may be. And then muscular imbalance, I would definitely expect all the pain issues and the repetitive motion, as well as I would expect asymmetry. Um, Full strength kind of against because if you had a muscular imbalance, then my assumption would be that your dominant shoulder would, like for instance, you would be able to resist less motion in external rotation versus internal rotation or vice versa or whatever. Definitely would expect, but wasn't mentioned, postural issues. So seeing the student with rounded shoulders, asymmetrical shoulders, scapular winging during motion, things of that nature, which just wasn't mentioned. Um, and also the muscular imbalance in my brain is very common in younger athletes because they haven't worked out these certain muscles, and especially in overhead, like these are not natural movements. So the external rotation, the eccentrics, things of that nature are all need to be worked on to get them up to that level. And so one thing that would have helped would be if we had some sort of history for how long the athlete has been participating in said sports or in said position. Because maybe they were an athlete for 16 years, but they just started playing volleyball or whatever the case may be. And then that would help push towards there being a muscular imbalance because they're just not used to this sort of movement.